Hello, my name is Dr. Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, wherever you get your podcasts from, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which run throughout the year. Now, we've had a request from one of our listeners for today's topic, which is echo scan referrals in primary care, and actually we did discuss this in our study groups in the last couple of years. Now, echo scans are obviously really important as part of a diagnostic tool to us in primary care. It's an essential tool, essentially, in a wide range of clinical scenarios, and we all know that the appropriate use of an echo scan can improve clinical outcomes significantly, and it does this by increasing diagnostic accuracy, by providing non-invasive or minimally invasive assessment of disease status and risk stratification, and it allows us to enable real-time monitoring and guidance of interventional procedures. Now, you don't need me to tell you that since COVID, we've had a dramatic increase in the waiting time for our patients to receive echo scans. And I think we need to look at when not to test with an echo as much as when to test. And this is really what I'm going to be talking about. Before I do that, just worth reminding ourselves about the three main types of echocardiography that's out there. We've got transthoracic, transesophageal, and stress. Now, the transthoracic, or TTE, this is typically performed with our patients lying on their left side with their left arm behind their head and the echo transducers placed in the intercostal spaces to the left of their sternum and in the anterior axillary line. Now, this is worth mentioning because it's the preferred investigation in valvular heart disease, because that echo shows that all four cardiac valves can be seen and tested, and other abnormalities in ventricular performance can also be assessed at the time. The transesophageal echocardiogram, unlike the transthoracic, is typically performed under sedation and also with facilities for resuscitation. So what we do is we give the patient a local anesthetic spray for the upper pharynx, and then an ultrasound probe is passed down into the esophagus behind the heart, and that then gives high levels of resolution of the patient's cardiac structures. Now, compared to the transthoracic echo, the transesophageal tends to provide much better views of the posterior structures of the heart, so things like the descending aorta and the left atrium, for example. And because of this, it's usually the echo of choice for the diagnosis of infective endocarditis and for looking at managing hypotensive patients in intensive care. It can also be used in the search for a potential cardiac source of thromboembolism. But compared to the transthoracic, it must be remembered this is an invasive procedure, and the patient does need to be fully aware of what's involved, and their consent has to be given. The stress echo is perhaps the least commonly used, and it can be used during or soon after exercise, but in this case, an intravenous infusion of dopamine may also be used to induce stress in a similar manner to exercise. Now, this is non-invasive, it is relatively safe, and it's excellent for evaluating our patients with coronary heart disease. And the rest and the stress images are both obtained and then compared. Now, if we're considering myocardial ischemia in a patient, this does have some benefits over the standard treadmill exercise testing that are so often done. So when we're just looking further at when we traditionally use echocardiograms, then there are the ones that we would always think about: valvular stenosis or regurgitation, aortic aneurysms and dissections, for looking at prosthetic heart valves, for consideration of established heart failure, for pericardial effusions, when we're diagnosing any masses within the heart, occasionally for ischemic heart disease, as with a stress echo, and when we're considering the possibility of congenital heart disease being present. Now, if we look at the conditions where an echo scan has a low clinical yield from us in primary care, and so because of this it's unlikely to affect patient management, then we're looking at things like heart murmurs. They have a low clinical yield. Suspected heart failure, and this is an important point. If you usually refer a patient for an echo with suspected heart failure, that will get bounced back. Unlikely in confirmed heart failure, which is entirely appropriate, but suspected heart failure has a low clinical yield from primary care, as does hypertension. When we're considering cardiac masses, whether we're looking at pulmonary disease, assessing causes of palpitations, whether we're considering pericardial disease, if we're looking at established cardiomyopathy or inherited cardiac disease, all these conditions have a low clinical yield from echo in primary care, and so this is why they are unlikely to affect patient management and are often rejected at referral. So looking at these in a little bit more detail, let's look at heart murmurs first. Now, we have no evidence of echo benefit. This is no evidence of any benefit from using an echo in someone who has an unchanged existing murmur and who is asymptomatic and who has had a normal previous echo. Also, there is no evidence of an echo benefit in the assessment of an innocent or physiological murmur, which obviously are especially common in high output states. I'm thinking of things such as pregnancy here. And these are typically defined as a systolic murmur of a short duration, or grade 1 or 2 intensity at the left sternal border. There are no other abnormal sounds or murmurs. There's no evidence of ventricular hypertrophy, there are no thrills, and there is no increase in intensity with the Valsalva maneuver. So the assessment of an innocent murmur has no evidence of an echo benefit, as does an unchanged murmur in someone who's asymptomatic with a previously normal echo. I mentioned suspected heart failure. Established heart failure, echo scans are an extremely useful and important tool. But with suspected heart failure, if you've got a patient with a normal physical examination, a normal ECG, and crucially a normal NT-proBNP blood level, then there is no indication for an echo, even if there is cardiomegaly on a chest X-ray. The presence of simple cardiomegaly on a chest X-ray does not warrant an echo in its own right, because the likely yield of identifying significant cardiac pathology is low. And I think that's an important point to remind us about, because we often do forget that one. If we're looking at our hypertensive patients, we've got a hypertensive patient who is normal with their physical examination. They have a normal 12-lead ECG. Should we be doing a routine echo? No, we should not. An echo is not indicated routinely to evaluate those patients. However, if you have hypertension in a patient under the age of 40, then you can quite validly trigger an echo to search for causes of secondary hypertension, which I'm thinking of things like coarctation of the aorta and looking for any end organ damage. On the other hand, echo surveillance is mandated in patients who are primary degree relatives of affected individuals who have inherited cardiac diseases. But the key point here, I think, is that an echo scan is not indicated routinely when we're evaluating patients with normal 12-lead ECGs and normal physical examination and primary hypertension. Looking at pulmonary disease, if you've got a patient with lung disease with no pulmonary hypertension and no clinical suspicion of cardiac involvement, then an echo scan is unlikely to affect their management. With palpitations, if you have a patient with classical vasovagal syncope, this does not require echocardiography, and nor does palpitations in a patient without any ECG proof of an arrhythmia or clinical suspicion of heart disease on examination. Inherited cardiac diseases are less common in primary care, obviously, but if there's a family history of cardiomyopathy, then a screening echo should only be undertaken in first-degree relatives, which is mandated, unless specialist guidance suggests otherwise. Echo scanning outside of this guidance for the frequency of repeat echoes with a family history of cardiomyopathy is unlikely to affect patient management. And if we've got clinically stable patients who have established cardiomyopathy, and there is no change contemplated in management, and their symptoms have not changed, then echo scanning outside of local guidance is also unnecessary. So I would avoid echocardiography in three main areas here. So avoid echo scanning in the absence of a change of patient symptoms or signs. There is no need in those patients to have a repeat echo for a repeat echo's sake. Avoid echo scans in patients with terminal diseases or significantly life-limiting diseases where an echo scan would not alter their management. And I would also avoid echo scanning in patients with significant frailty where an echo would also not alter their management. So I hope that brief overview and reminder about echo scanning referrals in primary care has been helpful. But do have a look at the show notes that accompany this episode at GPnotebook.com. And as always, we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. As always, do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But until the next time, as always, thank you for listening, and goodbye.